Hey guys, my webinar is on frontal lobe dementia, also known as frontal temporal dementia, which is abbreviated as FTD. So frontal lobe dementia is a group of disorders caused by progressive cell degeneration in the frontal and temporal lobes of the brain, and is also associated with non-Alzheimer's disease. It accounts for 10 to 15% of all dementia cases. And the picture on the right just kind of gives you a picture of the lobes and where we have learned where they're at on the brain. So the pathophysiology of this disease, there is cell damage in the frontal and temporal lobes that leads to tissue atrophy and then reduced function. So there's deficits in planning and judgment, emotions, speaking and understanding speech, and certain types of movements. There's also changes in personality, behavior, and communication. Some behavior changes that often these people might have are loss of insight, disinhibition, apathy, mood changes, stereotypic behavior, as well as eating behaviors. The primary neurodegeneration of the anterior temporal and or the frontal lobes is affected, and the only known risk factor for this condition is family history of the disease. So for the classification of this condition, it is defined by the age of onset and location of the neuropathy to determine the mechanism of neurological damage as well as the behavior presentation. Subtypes are developed and identified based on the neurological and behavioral symptoms presented by the patient. You cannot receive a diagnosis based on the neurological changes alone because it can mimic other conditions as well. Like I said, it's differentiated from other types of dementia based on behavior changes, including depression, apathy, disinhibition, progressing language dysfunction in the absence of initial memory impairments as well. So the three clinical subtypes that have different core symptoms, but there is also an overlap of symptoms as the disorder progresses. The first one is behavioral variant frontotemporal dementia, so BVFTD. It affects personality and behavior. The second one is primary progressive aphasia, PPA, and this affects language skills early, and then also the behavior is more affected in the advanced stages. Another subtype under this category is semantic dementia. This is where people can speak easy, but the words have less and less meaning. So they tend to use broad terms when they're talking about things. So for example, they use animal when they mean to, like say cat or dog or something like that. And the last subtype is progressive non-fluent aphasia, and this is where patients lose the ability to recall words easily and speech grows more difficult. So for the clinical presentation for these various subtypes, for frontotemporal variant, there is bilateral symmetrical frontal lobe damage and behavioral changes. For progressive non-fluent aphasia, there's asymmetrical atrophy of the left frontal and temporal lobes, and you will also see language disturbances because of where it's affected on that lobe. And then for semantic dementia, there is bilateral damage to the anterior temporal lobes. So some signs and symptoms that you will see with a patient with this condition is inappropriate actions made, as well as apathy, a lack of inhibition or restraint, neglect of personal hygiene and care. They often have compulsive behavior, difficulty speaking or understanding speech, and they also have language recall problems. So for the diagnosis of this condition, one article that I found looked at diagnostic features, and this was based off the London and Manchester groups, and it requires the presence of at least two of the following features, which include loss of personal awareness, reduced social appropriateness, mental rigidity, strange eating habits, perturbation, or mood change. And they must also present with one or more of the following: frontal executive dysfunction, reduced speech output with relatively preserved visual spatial ability. So some more features for the diagnosis of this condition. There is no one single test that can for sure diagnose it, and it's oftentimes a clinical diagnosis. MRIs can be used to detect shrinkage of the frontal and temporal lobes, and this is the hallmark sign of FTD. Patients can also undergo a CAT scan, blood test, neuropsychological testing, but they've found that it's often difficult to distinguish from Alzheimer's disease because of the similarities in presentation that the patients present with, and it just makes it more difficult to actually diagnose it. And in another article I found too, it stated that like with Alzheimer's and dementia patients, you can't often for sure have the diagnosis of this condition until an autopsy is done after the patient has passed away. So this is just a slide comparing FTD and Alzheimer's. So as you can see, it kind of maps out the differences, between both conditions. So FTD is diagnosed in the 50s and early 60s. Alzheimer's grows more common with increasing age. With FTD, there's memory loss in addition to behavior and language, and with Alzheimer's, there's just memory loss oftentimes. With FTD, behavior changes are early. They are not common to have spatial orientation loss. There is more difficulty making sense when they speak or understanding speech of others, as well as reading. And they oftentimes have it is uncommon that hallucinations and delusions are present with people with this condition. Now for Alzheimer's, their behavior changes are later in the disease. It is more common to have problems with spatial orientation. They have less difficulty making sense when they speak, as well as understanding speech of others and reading. And for these people, it is relatively common to experience hallucinations and delusions. So again, this kind of just sums up the differences in FTD when comparing it to Alzheimer's disease. So here's just a picture of a scan showing the brain, and you can see on the far left is a normal aging brain, and in the middle is someone with Alzheimer's disease, and then on the far right is a patient with FTD. It's also known as Pick's disease, and so this kind of just shows the changes in the brain and what happens to the lobes. So you can just take a look at that. There are different treatment interventions for a patient with FTD. There are pharmacological interventions. They can also have speech therapy, and there's also lifestyle modifications that can be made. And again, the picture just here kind of represents the differences between FTD and Alzheimer's disease and where it affects in the brain. So for pharmacological treatment, currently the FDA has currently not approved any treatments for FTD. Research indicates that there are various classes of medications to help, but their use is limited due to the adverse side effects. So some medications that have been used on patients are SSRIs, atypical antipsychotics, acetylcholinesterase inhibitors, and then NMDA glutamate receptor antagonists. But like I said, research is very scarce for these, and oftentimes people are not given these medications due to how bad the side effects are and how they can interrupt with a bunch of other things as well. So another option that patients have if they have FTD is to get involved with speech therapy. This helps patients learn to deal and cope with their speech difficulties that they have that come along with the condition, and it also gives them another way to figure out something different or something new maybe that can help them communicate better with people because of the changes they are facing with their disease progression and process. There are also lifestyle modifications that patients with this condition can do to help, increase their quality of life and just make things better for them. They can, it's important to help the patient find a comfortable and engaging environment that's going to stimulate them, but also keep them, at a level where nothing is going to push them over the edge or it's going to be too much. It's important also to maintain an environment that does not upset the patient, that's also familiar to them and does not contain a large group of people, because this can often upset the patient and make them really, really frustrated if they have difficulty speaking or if they're at that point where it's difficult to interact with others or a large group of people. And it's also important to be in an environment where communication is easier. So this just makes it overall better for the patient that they can try to figure out what they're doing and whatnot, so it's just easier to communicate with people and be able to articulate what they want or what they're trying to do and stuff. So then there's the question, is physical therapy indicated? Research indicates that a combination of pharmacological therapy plus behavioral, physical, and environmental modification techniques is the most effective management of FTD. There is no specific indication or research suggesting that PT as an intervention. However, according to research, several RCTs have shown that aerobic exercise may improve neuronal connectivity. So this may be something that you still would want to prescribe to a patient, but it would also depend on the patient presentation. So it's important to recognize the early signs and symptoms of this condition. So then it's important to think, so do we treat and refer, or refer? And I want you to try to think about that. And what would you think that you would do with a patient who, with this condition, or if you noticed the signs and symptoms of a patient like this and noticed that something was off, or something wasn't right, or they weren't their normal selves, what would you do in this situation? So the prognosis for a patient with this condition is poor. Currently, no cure exists at this time. The disease progresses faster than patients with Alzheimer's disease. It is progressive, and it is also irreversible. The management is also limited, so this kind of just puts a damper on it, because we don't really know for sure, what's the most beneficial thing to help them besides keep their quality of life and improve their functionality as much as possible, or help them maintain that. Also, people with this disease tend to live an average of 6 to 8 years only after their first symptoms are recognized or diagnosed. So in summary, FTD is caused by the progressive cell degeneration in the frontal and temporal lobes of the brain. The symptoms that are associated with this condition are behavioral and language issues. Those are the biggest ones. Shrinkage of the frontal and temporal lobes is the hallmark sign of this condition, so it's important to be aware and look out for that. The primary treatment is a combination of pharmacological, behavioral, environmental, and physical techniques. And there's also limited research on the management for interventions and indication of physical therapy for patients with this condition, but it's important to remember that we want to try to maintain their quality of life and their functionality. So, keeping that in mind, whether you're seeing them or referring them to someone else, but that's going to be the biggest thing. It's just helping them to live their life now as they are, as this disease is progressing through their lifespan and stuff. So here's just a slide of my references and a couple websites if you want to access any more information about it. Feel free to ask questions, or just ask me in class if you do have a question about anything. Thank you.